In this video, we provide a step-by-step description of how 3D fusion overlay imaging can be utilized to reduce radiation dose, contrast volume, and surgery time during fenestrated endovascular aortic aneurysm repair. This patient is an 85-year-old man who presented with an abdominal aortic aneurysm measuring 6.1 centimeters in maximal diameter. The infrarenal neck measured 4 millimeters in length. In order to utilize a 3D fusion roadmap, we begin each endovascular aneurysm repair with a 270-degree spin of the C-arm prior to prepping and draping the patient in order to acquire a dynamic CT dataset. At this point, we are lining up the patient in the C-arm in the AP and lateral planes in order to make sure that the area of interest is centered in the field of view. We then perform a test spin in order to make sure that the gantry is clear of any obstruction. We now exit the room in order to limit radiation exposure to all OR personnel and perform the 270-degree spin of the C-arm. At this point, we call in the preoperative CT angiogram and fuse it with the dynamic CT that we just obtained. Using easily identified bony landmarks, we line up our pre-op CT with our dynamic CT and register the fusion. We now take the bones out of view and switch to the preoperative CTA vascular reconstruction view, which is now fused with the on-table dynamic CT. This gives us a 3D fusion overlay that can be used as a roadmap throughout the entire case. In the setting of adequate access vessels, we prefer an ultrasound-guided percutaneous approach. We have now introduced our main device and aligned the renal fenestrations with the renal artery target vessels. We are working with a VS1 catheter to facilitate cannulation of the target left renal artery. After advancing our catheter, we change out to a stiffer Rosen wire in order to advance a 7 French Ansel sheath into the target left renal artery. We now turn our attention to cannulation of the right renal artery. We have advanced the glide wire through the right renal artery fenestration and into the target right renal artery. We now advance the C1 catheter in order to change out to a stiffened Rosen wire in order to advance a 7 French Ansel sheath into the target right renal artery. We then position a balloon expandable stent graft in each target artery, remove the diameter reducing ties, and deploy the bare stent at the superior aspect of this device. At this point, we use a coda balloon to approximate the proximal seal zone. Each renal artery bridging stent graft is then deployed with approximately 4 millimeters of stent graft extending into the fenestrated device. We then flare the proximal stent graft with a 10x2 angioplasty balloon. We now perform bilateral renal arteriograms with a total of 4 cc's of contrast to confirm seal at the fenestration and intact renal artery perfusion. We now orient the distal bifurcated device externally in order to position the contralateral gate in a favorable orientation for cannulation. With the distal bifurcated device in place, with a minimum of 2 stent overlap, we now remove the wires and sheaths from both target renal arteries and deploy the distal bifurcated device within our approximated fenestrated device. In order to facilitate gate cannulation, we deploy to the level of the contralateral gate. After confirming proper cannulation of the contralateral gate, we use an iliac extension limb to build the graft down to the level of the common iliac artery bifurcation. Similarly, on the left side, we deploy the rest of the ipsilateral limb to the level of the common iliac artery bifurcation. All junctions and distal seal zones are then approximated with the use of a coda balloon. Completion arteriography demonstrates exclusion of the aneurysm, with preservation of blood flow to the celiac, SMA, and bilateral renal artery. All sheaths and wires are removed, the perclosed knots are secured, dermabond is used to approximate skin edges, and the procedure is concluded. For this repair, the total radiation dose administered was 987 gray, the total contrast use was 18 milliliters, and the total operative time was 111 minutes. 1 month follow-up CT demonstrates an intact repair. In summary, 3D fusion overlay imaging is an important adjunct for reducing radiation dose, contrast volume, and surgery time when performing fenestrated endovascular aneurysm repair.